Hello, my name is Dr. Janine Villela, and I am the Vice Chair of Gynecology and the Chief of Gynecologic Oncology at Lenox Hill Hospital. I'm an Associate Professor at the Zucker School of Medicine. Welcome to the inaugural Jane Ades Gynecologic Cancer Symposium. I am dedicated to improving screening, diagnosis, treatment, and outcomes of women with gynecologic cancers. I believe that all-inclusive care of gynecologic oncology patients delivers the optimum continuity of care tailored to a patient's needs. Education is an integral part and is very essential to complement clinical therapies and support recovery and wellness. With that said, we have a wonderful educational content prepared for you today, including everything you need to know about endometrial cancer, including risk factors, tools to lower your risk, diagnosis and treatment options, and comprehensive care to thrive through and beyond cancer. At the end of the symposium, there will be an opportunity for questions and answers. We encourage you to ask questions. Thank you for joining us today, and we hope that you are empowered and informed by this symposium. This event is made possible by a generous gift from Paul Ades and his family in memory of Jane Ades. Paul and Jane were together for over 50 years, and they raised 3 sons. She was a devoted wife and mother, a leader, educator, and a caregiver. She was taken far too early due to an aggressive subtype of endometrial cancer. This symposium honors Jane's commitment to education. She served as a teacher for her children, grandchildren, and members of her congregation and her community through her literacy work at the local library. Thanks to the Mr. Ades and his family's generous support, we honor Jane's legacy by developing a program that will increase early diagnosis, prevention, and improve outcomes and quality of life for women at risk or affected by gynecologic cancers. This educational symposium is one part of this larger program. Our sincerest thanks to Paul and his family for making today's event possible. Now, it is with great honor and pleasure I introduce to you our dear friend and Jane's beloved husband, Mr. Paul Ades.
Good afternoon. My name is Paul Ades, and I've been asked to say a few words as to the sponsorship of this program by my family. My wife, Jane, who passed away regretfully about, it's almost 12 years, woke up one morning in April. I remember the morning very clearly. And just yelled out from our bathroom, "I have a spot of blood and I'm nervous." I was completely naive. I had no idea what the problem was. I had no idea that this little spot of blood could cause this much problem to a woman Jane's age. It just was beyond me. But eventually, after going through seeing her doctor and a number of tests, it was determined that it was endometrial cancer, and Ben Schwartz, her oncologist surgeon, came to talk to us afterwards, and he said that it was stage 4, and he would try and treat it. But the problem with endometrial cancer was that it's a hidden cancer inside a woman's body that you don't see until it's maybe stage 4 when it presents itself. After Jane passed away, and Ben did a great job at trying to prevent that, I determined with talking with my children that we wanted to do something in Jane's memory, and that was to do some research and more study into endometrial cancer. I became involved with the hospital, which is now South Shore University Hospital, and obviously within the Northwell system, and made known my desire to support some research in this area. And that was the beginning of what Dr. Villella is doing as far as researching endometrial cancer and this symposium on endometrial cancer. All we're trying to do is to prevent the pain that we went through. Over the years, I see articles that endometrial cancer is just unknown until it's too late. And I don't want that to happen to other people. So this is the purpose of the research, to learn how to diagnose endometrial cancer and hopefully to cure it before it gets to a point that it's incurable. I wish Dr. Villella all the success. It's a program that my family will continue to support. We feel very close to it. In talking with Ben Schwartz, who is Jane's oncologist, he said there's just very little that people know about it, at least then, 12 years ago. And that's the purpose of where we're going. After this, I'm afraid I'm going to repeat myself. So we dedicate this to the memory of my wife, my children's mother, the grandmother. And I wish you all success in your research. Thank you.
Thank you so very much to Mr. Paul Ades, who graciously is supporting this program on behalf of his late beloved wife, Jane. I'm honored to be given the opportunity to purpose the Jane Ades gift to educate, prevent, and care for women with endometrial cancer, and to learn more about what drives the development of this disease. So what is uterine cancer or endometrial cancer? Well, the uterus is an organ that sits between the bladder and the rectum. It's about the size of your fist in most circumstances. And most uterine cancers begin in the inside lining of the uterus, called the endometrium. And this is the cancer that we will be discussing today. Rarer forms develop within the actual muscle of the uterine wall, and this is called the uterine sarcoma, and that is managed differently. The cervix is the lower part of the uterus. However, when you have a pap smear that is cervical cytology, it is not a screening test for endometrial cancer. And in fact, there is no screening test for endometrial cancer. So uterine cancer is the most common gynecologic cancer in the United States. In fact, we have an epidemic of endometrial cancer in the United States. Over the past 10 years, there has been a 57% increase in new endometrial cases, which makes it the fastest growing cancer in women. What is also concerning is that it is growing by 1 to 2% per year in women less than 50 years old. There are over 65,000 new cases diagnosed per year and over 12,000 deaths. In 2010, it was the 8th most common cause of cancer death in women, and to 2016, when it has become the 6th most common cancer cause. This is much in part the increase in incidence, but that is not the only cause. Over the last 3 decades, Black women have an increase in disease diagnosis and a 20% less survival rate than white women with this disease. This is an unmet need in cancer care. There are many risk factors for endometrial cancer. One is age. The average age of endometrial cancer is 61. However, we are seeing an increase in pre- and perimenopausal women who develop endometrial cancer. Before menopause, a woman's ovaries normally produce 2 main types of hormones, estrogen and progesterone. Estrogen encourages the growth of endometrial cells in the uterus, whereas progesterone inhibits it. When a woman has circulating levels of estrogen and low levels of progesterone over long periods of time, the risk of endometrial cancer arises. And this is because endometrium and estrogen acts like a fertilizer for the endometrium and causes uncontrolled growth, which is what defines cancer. These changes develop over time and have the potential to spread based on their loss of ability to regulate themselves. This occurs in conditions such as early menarche or late menopause, never having been pregnant, having polycystic ovarian syndrome or anovulation, and women with a long history of abnormal menstrual cycles. Also, women on tamoxifen and those with precancerous endometrial tissue or hyperplasia are at increased risk. In fact, endometrial hyperplasia or precancer can be associated with a 42% chance of endometrial cancer. We will be hearing from Dr. Roslin on why obesity increases cancer risk. But in endometrial cancer cells, because in fat cells, there is a conversion of some compounds into molecules that act like estrogen and cause uncontrolled growth of endometrium. Therefore, obesity is also a risk factor for developing endometrial cancer, and that risk increases as your weight increases. In a similar way, diabetes changes the body's chemistry, favoring an increase in estrogen levels. Family history and hereditary cancer syndromes, such as Lynch and Cowden syndromes, also increase lifetime endometrial risk, especially in young women. The most common presenting symptom of endometrial cancer is bleeding or spotting. In fact, 90% of women present this way. If you have postmenopausal bleeding, there's a 10% chance of having endometrial cancer, so it's very important to seek medical attention. The risk of endometrial cancer also arises if you have premenopausal bleeding or perimenopausal bleeding in your late 40s or early 50s. Also, abnormal uterine bleeding in premenopausal women in the late 30s to early 40s, which present with prolonged heavy menses or bleeding between menses, is a risk factor. Even vaginal discharge that is watery or pink. It doesn't have to actually be bright red or any heavy bleeding, but with risk factors or in postmenopausal women, this needs to be evaluated. Other symptoms include difficulty or pain with urinating, pain during intercourse, pelvic pain, or unexplained weight loss. The take home here is you must listen to your body and seek medical attention. Once you have symptoms and seek medical attention, your workup will include a comprehensive history and physical, including a rectal and a vaginal exam. This is important because if you remember the diagram I showed you in the beginning, the uterus sits between the bladder and the rectum. So the best way to feel it in its entirety is on rectovaginal exam. You may have a pelvic ultrasound to see if the lining looks abnormal, and then a tissue diagnosis. This can be done by endometrial biopsy in the office, where a small pipelle, pictured here, is passed through the cervix into the uterus, and a small suction of tissue is obtained. This is often associated with a little crampy discomfort that is relieved shortly thereafter, either self-limiting or with one dose of Tylenol or Motrin. In some cases, the physician would like to look into the uterus, for instance, if the ultrasound might show a polyp, in order to remove it in its entirety and sample the remainder of the uterus. That is called a dilation and curettage polypectomy and hysteroscopy, and this may be done in the operating room or in the doctor's office. The reason tissue diagnosis is advantageous is because there are many types of endometrial cancer, and each type varies in the way it behaves and may affect how it should be managed. For instance, endometrioid adenocarcinoma is a type of uterine cancer that is very common, and it's most oftenly associated with early disease and high cure rate. It's most commonly associated with obesity and estrogen excess, and as much as 75% of all uterine cancers are of this cell type. Whereas serous, clear cell carcinosarcoma or adenosquamous carcinoma are aggressive cell types. And in order to determine the spread and plan additional treatment, your doctor may order CAT scan, MRI, or PET scan. While we will learn that surgery is the standard treatment of endometrial cancer, as we have heard, endometrial cancer in younger women is increasing 5% of cases diagnosed in women are less than 40 years old. This incidence is also rising in this group. Candidates for treatment for fertility sparing are those who are caused by estrogen excess, such as abnormal menses, polycystic ovary disease, obesity. We will have to consider that fertility preservation is very important to these young women. The majority of patients would prefer to have biological offspring above options such as adoption and surrogacy. So those patients with low risk uterine confined endometrial cancer on physical exam and imaging, well differentiated, the patients have no other known cause of infertility, patients who desire to have children, are able to receive hormonal therapy, and are compliant as patients need repeated evaluations if fertility sparing options are taken. These treatments for fertility sparing are centered around progesterone, and that is what counteracts or balances out the excess estrogen that causes the endometrial cancer in these patients. In fact, we are involved in a clinical trial looking at targeted agents to improve the response to progesterone therapy in these women. Patients need to have repeated endometrial sampling and may need a repeat course of therapy. These are the types of patients that we also may send for complementary lifestyle modifications such as nutrition, exercise, bariatric surgery for medical weight loss management. So we know that surgery is a cornerstone of treatment for endometrial cancer. For many women, it is used for removing the cancer as well as the diagnosis and staging information. It also prevents and stops the abnormal bleeding. These steps can be completed over a course of a single surgical procedure. The main objective is hysterectomy, and in most but not all cases, removal of the ovaries. Sentinel lymph nodes is a procedure that takes a small sample of lymph nodes to examine for cancerous cells under a microscope. This is done using a fluorescent green dye that is injected into the cervix just before the hysterectomy. This is a very big advancement in the progress of endometrial cancer therapy and has decreased the burden of lymphedema, which is a chronic and often debilitating chronic swelling in the legs that occurred in up to 15% of patients when we have done more extensive lymph node removal. In addition to our expertise in sentinel lymph node biopsies, we offer many surgical procedures for endometrial cancer patients using the most advanced technology available to perform surgery with exacting precision. We perform regularly leading-edge, minimally invasive surgeries such as laparoscopic and robotic surgery, which offer benefits such as reduced risk for infection, faster recovery, improved cosmesis, and less pain. With laparoscopic surgery, the surgeon first examines the pelvic cavity with a laparoscope, which is a thin lighted tube with a video camera on its tip, which projects an image into a large viewing screen. Guided by the laparoscope, the surgeon operates through tiny ports, which are small tubes placed into the abdomen using specially designed instruments to remove the uterus through the vagina. This has been groundbreaking, and in fact, many patients go home the same day of surgery. Those patients with advanced disease, they may need what we call a debulking, which is a radical procedure, often through a vertical cut on the abdomen and removal of multiple organ sites or partial organ sites affected by metastatic disease. In obese women, since we know that obesity is common with women with endometrial cancer, we may collaborate with bariatric surgeons to combine hysterectomy and staging with bariatric surgery as needed for weight loss. Combining surgery does not compromise surgical outcomes, and there also are patients who are simply just not surgical candidates. Staging is important because it lets us know if the cancer has spread. This determines if you need any additional therapy and allows your doctor to determine prognosis or outcome. Stage 1 and 2 were the most common, where over 80% of cases are diagnosed. And these patients have a 5-year survival rate that are over 70 to 96%. Advanced stages 3 or 4 are about 20% of all patients and have 5-year survival rates ranging from 10 to 20%. This underscores the importance of early diagnosis. With recent advances in testing, understanding of the disease, we know that it's very important to get further testing on the tumor and potentially the patient. An endometrial cancer patient should be sure that all tumors should be screened for hormone receptor status for potential of future therapy and further characterization of the tumor. Additionally, DNA mismatch repair proteins or microsatellite stability markers should be investigated. This is a test on your tumor that sees if your cancer has the vulnerability in the way the cancer grows and makes it susceptible to immunotherapy. If she has advanced disease, and it will also know if the patient needs to have genetic testing by blood or a mouth swab to see if she can pass the gene down to her family members or she will be susceptible to other cancers such as colon, ovary, and bladder cancer. These tests may drive the choice of adjuvant or additional therapy and may glean prognosis of this disease. As we discussed, surgery is generally considered for this disease, and the majority of patients will be cured from this modality. In early stages, minimally invasive surgery may be the only treatment they need. And in most cases, we only recommend therapies such as chemotherapy, hormonal therapy, or radiation therapy if the cancer has spread deep into the uterine muscle layer or beyond, or based on aggressive cell types. In later stages after surgery, additional treatment is required to kill microscopic cells that are undetectable. The goal of radiation therapy is to treat locally to the pelvis and the lymph node areas, any microscopic cells that we could not see or feel. Brachytherapy is aimed at the vagina, since this is the most common place for cancer recurrence. This modality can give a higher dose of treatment to the vagina without toxicity to the bladder or rectum with external beam radiation therapy to the pelvis. The goal of chemotherapy is to kill cancer cells that may have escaped distantly or to shrink tumors that could not be resected at time of surgery. Other modalities of therapy are combined modalities with hormones and immunotherapy, and we advocate for all of our patients to enroll in clinical trials if indicated. So we know now that there is no one-size-fits-all therapy, and we need to treat based on a multitude of factors. And in fact, we now use precision therapy to guide any additional therapy based on a patient and tumor factors while looking at drug effectiveness and toxicity to come up with an optimized interaction and improved quality of life. We know that women in 2022 are working and taking care of loved ones who depend on them. So we need therapies that, while are effective, are still compatible with their daily activities of life. Over the past 10 to 20 years, scientists have been looking to how to use the immune system to recognize and fight cancers. As a result, dramatic increase of the number of immunotherapy clinical trials was seen in the past decade. In fact, it was a scientific breakthrough of the year of 2018, and this year, a breakthrough in endometrial cancer has shown tremendous promise. These two physicians, one of which I've had the pleasure of hearing present his work, won the Nobel Prize in 2018. You may have even seen the ads on television for an anti-CTLA-4 drug called Keytruda, and much of their work led to the development of this drug and others of the same classification. This has been groundbreaking in cancer care in general, but also with endometrial cancer because it's very effective in patients with microsatellite high tumors. And while chemotherapy is very important to the management of aggressive cell types, advanced stages, or recurrent disease, although we have gotten better at improving side effects, we also have made some progress in immunotherapy by clinical trials. Clinical trials are very important because it's one of the ways we get access to excellent cutting-edge care. Oftentimes, institutions that have clinical trials that have expertise in these areas, such as Northwell, and this happens to be my area of expertise. For endometrial cancer, clinical trials are very important because of the availability of immunotherapy. These drugs harness your immune system to fight cancer. Regular chemotherapy kills normal cells and cancer cells, and this is why in some way nonspecific kill occurs. This is why patients on chemo, they also lose their hair, and also why they may be nauseous or have diarrhea because it kills actively dividing cells in your scalp, in your hair follicles, as well as your stomach lining. Immunotherapy uses our body's own immune system to activate or deactivate cells to kill cancer cells specifically. These can be vaccines, which are tumor specific and can learn to kill cancer. Checkpoint inhibitors that manipulate immune cells to prevent the off signal from being sent, allowing your own body's T cells to kill cancer cells. One such drug acts against checkpoint protein called the CTLA4. Antibody therapy kills cells directly, and they may block development of tumor blood vessels, or they may block the ability of the tumor to proliferate. So why choose Northwell for uterine or endometrial cancer care? Well, we've got you covered. We offer comprehensive care, which is holistic. You may be seen by some or all of these providers or utilize some or all of these services. And while we offer the most cutting-edge cancer care available, we truly care for each patient with dedication and compassion. Beginning with your first appointment, our team will walk you through the entire treatment process, making sure you know what to expect. We create a unique, personalized plan for every patient and consider all aspects of your health while making recommendations. We are creating the future of cancer care by bringing together top-rated cancer specialists and team members who specialize in oncology, state-of-the-art technology, and leading-edge clinical care and research. Northwell is an integrated system for all of your medical needs throughout your lifetime. We have the ability to care for the whole person beyond their diagnosis on a full spectrum of care within one integrated health system. We serve a very diverse population of patients from the tri-state area, and if you need us, we will be here for you. I would like to introduce to you Dr. Mitchell Roslin. Dr. Roslin is the Chief of Bariatric and Metabolic Surgery at Lenox Hill Hospital and Professor of Surgery at the Zucker School of Medicine. He will be speaking to you about tools to lower your risk of gynecologic cancer as it relates to obesity. Let's hear from Dr. Roslin now.
Hi, I'm Dr. Mitchell Roslin. I'm the Chief of Bariatric and Metabolic Surgery at Lenox Hill Hospital and a Professor of Surgery at the Barbara and Donald Zucker School of Medicine. And I'm really grateful to have this opportunity to speak to you today at the inaugural Jane Ades Cancer Symposium. Again, I'd like to thank the Ades family for making this possible. And I'm sure everybody's wondering why a bariatric surgeon who focuses on GI surgery and weight loss will be speaking in a presentation and symposium on endometrial cancer. And I think what I'm going to tell you, you'll find most interesting and I think very, very helpful. So you're probably thinking, why would somebody who focuses on the gastrointestinal tract and treats weight loss, tries to achieve weight loss, be speaking on cancer? When we think of heart disease and diabetes, we think of nutrition and what we eat being the cause. But when we think of cancer, we think of something happening in our genetics, happening in our DNA, or being exposed to cigarette smoking. But we generally don't think about what we eat or our activity level or obesity as being the cause. But the true answer is that obesity is very, very, very much related to cancer. In fact, before the 1900s, cancer was very rare. And at the turn of the century, at the beginning of the 1900s, people considered cancer to be a disease of civilization. And when you look at the last 100 years where we've had an obesity epidemic, we've seen an increase in the number of cancer deaths throughout the entire world. So wherever there's been Westernization and the Western diet, we've seen an increase in cancer. So this is really, really interesting. When we look at, some of the cancers that are related to obesity, and one of the ones that's most pronounced is endometrial cancer or uterine cancer, where if you're significantly obese, your odds of cancer are 4 times more likely. The CDC has actually identified at least 13 cancers that are caused somewhat by obesity. And what's even more remarkable is, let's just take a state at random like Louisiana. Louisiana has the fourth highest rate of cancer deaths in the United States. And when we look on the other side of this slide, we see that Louisiana also has the fourth highest obesity rate in the country. So it's absolutely remarkable that we can superimpose a graph of obesity and the prevalence of obesity and the prevalence of cancer deaths. And several things happen when you're obese. Number one, the likelihood of cancer increases. The cancer is more likely to present at an advanced stage, and it's also more difficult to treat. So to try to understand, I think it's really important that we backtrack and understand what a cancer cell is. We use these terms, and most people are really, really confused. So normal cells will divide and have a life expectancy and almost a pre-programmed death. They'll only grow where they're supposed to grow, and they eat differently. Cancer cells, as you can see in the diagram on the right side, basically grow into infinity. They keep growing. They don't die, and then they grow into areas where they're not supposed to, so-called metastases or invasiveness. They grow across boundaries. In order to do that, they kind of seed their own blood vessels. And what's really, really fascinating is that they eat differently, where we know our body requires oxygen. The combination of oxygen and food is how we get energy. But cancer cells eat differently. They kind of ferment, almost the same type of reaction that you see when you make yogurt and things that are fermented into lactic acid, or the way alcohol is made. For example, if you keep grape juice out long enough, it's going to ferment into alcohol. And they use what's called glucose, or what's called aerobic glycolysis. So cancer cells eat differently, and we use that therapeutically if anybody's had a PET scan. So at the turn of the century, in fact, there was a very famous investigator by the name of Otto Warburg. The story of Otto Warburg is really fascinating. He was actually a gay Jewish scientist that was actually able to survive in Nazi Germany. And very, very early in the turn of the century, Otto Warburg identified that cancer cells basically predominantly ate glucose and were basically mandatory fermenting, that they kind of didn't eat the same type of respiratory things that, normal cells do. And he felt that there was a great link, in fact, that that was actually the cause of cancer. And at that time, there were a lot of people that came up with the idea, well, if cancer was caused by eating, having glucose, that potentially you could starve the cancer to tumor by using nutrition. Well, in itself, that really didn't work very well. And many of the thoughts of Warburg were forgotten for many years, especially when we began to identify DNA and we saw that different tumors had different genetic foci. So in the United States, we were kind of taught that what happens is the DNA oncogenes or something like cigarette smoking changes your DNA, causes a mutation that causes this endless growth. And we kind of forgot about the metabolic theory of cancer. But what happened as we saw the obesity epidemic turn is we realized that these things probably relate together. And whether obesity is the cause of cancer or just the spark or the kerosene that kind of ignites it is really what's disputable at the present time. So let's backtrack. And if we now know what cancer is, what's obesity? And the true definition of obesity means that there's excess adiposity or excess fat. And for years, we kind of just thought it was an energy balance phenomenon. In other words, I took in more calories than I ate, so it should just be like accounting. It should be very easy to treat. I should just go to the bank and deposit, withdraw more calories than I take in by being more active. But we've learned that the fat tissue is a very active tissue, and it causes an inflammatory response. Additionally, we've learned that when people eat less, their body becomes more efficient. It kind of results in them down-regulating the amount of energy they lose to counterbalance the weight loss. And stated differently, When they exercise more, they eat more, and it becomes like a vicious cycle. So we're in the midst of a true obesity epidemic. What's been really interesting in our research, though, is that classically, humans basically can burn different types of energy. So just like there are hybrid cars, as humans, we're hybrids as well. So what do humans and mammals do? So for example, plants get their energy from the sun, and they form these carbon-hydrogen bonds that create energy. The energy comes from the sun. Humans, mammals, and animals can't get energy directly from the sun. So we have to get our energy from the carbon and hydrogen atoms that plants produce or that animals eat and then turn into a higher source of protein for us. So our energy comes from fats, carbohydrates, and proteins, and then we react that with oxygen. And we burn different fuels depending on our need. If we're healthy, we tend to burn fat at rest. And then as we start exercising, we burn predominantly fat until we start working really hard. So you can think of a hybrid car. When it's idling, it's burning basically electric, but then it starts burning gasoline. In humans, the gasoline at a high level is things like glucose, but at rest, we should be burning fat. What's really interesting is that when we look at obese people, they lose that ability to burn different fuels. So within the human body, the powerhouse is called the mitochondria. Mitochondria are these energy-producing parts of our cells. And it's really interesting. You inherit all your mitochondria from your mom. And mitochondria are what burn fat. And what happens as you get older is you lose some mitochondrial function. So it makes sense when somebody tells you, I used to be able to eat everything, and now I can eat very, very, much less, and I still gain weight. The other thing that's really, really true is that it changes depending on your diet through the course of your life. And it begins to explain that obesity is a progressive, debilitating condition. And really, what I believe the key deficit is the inability for the hybrid car to work properly. So when we go ahead and we test people who should be burning predominantly fat at rest, just like the cancer cells, they burn predominantly carbohydrate. So what this is telling you is that the food that cancer needs is kind of the environment that cancer needs is kind of accelerated in people in obesity. And this is a person who was obese that we tested, and we expect people to burn about 80% the fat at rest. And this person burns about 100% carbohydrate. And what's really, really interesting is that what do we tell people to do to lose weight? We tell them to exercise even harder. But when they exercise harder, they're only burning the glucose. They're not burning fat. And remember what obesity is. Obesity means having excess fat. So it's really rather remarkable that the deficit that we're seeing in our patients is that they're likely to store fat, meaning they put a lot of money in the bank, but they can't withdraw that money and they can only burn sugar. And this is an example of what a normal person should be. The yellow is where you're burning fat. And this is how we exercise somebody. And you can see they start burning a lot of yellow. And then as they exercise more, they start burning more purple. And this is one example. And this is another example, which is a little bit more mixed. And this is what we should be seeing and not what we see in obese individuals. So what has happened is our diet has changed. And what has changed in our diet has been processed food. And processed food has something in it called fructose. And fructose seems to be one of the most important things. And fructose is present in fruit. It actually means fruit sugar. But everywhere where fructose exists in nature, it exists with fiber. And where fructose is different is that rather than form energy when it's eaten, it actually causes a breakdown of energy. And when that breakdown of energy occurs, it actually destroys the mitochondria, and the mitochondria are where you burn fat. And it gives the body a signal that the body is under some degree of stress and should store fat. and shifts the energy consumption to people to mainly being burning carbohydrate. So what does this sound like? It sounds exactly alike what Warburg talked about and what cancer cells like. And some things that I think are really important is there's been some wonderful books written about this called Metabolical and Toxic Food. And those books are mainly focused on the risk of heart disease, the risk of strokes, the risk of diabetes. However, there are many other things that are coming out, such as the risk of cancer, especially endometrial cancer, as well as the risks of infertility, low testosterone, joint disease, and even dementia. So the foods that we eat are really, really, really important. So what has evolved is we now have a population that is overfed, but undernourished. And we need to understand that it's the processing of food, the addition of things like fructose-free, corn syrup, and putting in man-made fats and taking away the fiber from our diet that is creating an environment where we are more likely to store fat than burn fat and rely on only glucose metabolism. So obesity is very, very ironic. It's absolutely ironic that eating fat doesn't cause fatty liver, eating bad carbohydrates probably do, and that obesity is defined as excess fat. But the main problem is we don't oxidize fat, we only store fat. And one of the major issues is that the labs that we get are often too late. Once we start seeing a rise to diabetes, you've already had a high insulin rate for a long time. And it's the high insulin rate, which is the body's growth factor, that causes a lot of the negative things, and many people think are responsible for the unregulated growth of tumors. So it really remains to be seen whether obesity is the ignition. In other words, the burning of different fuels changes the genes that mutate, that go on to cause cancer. Or is obesity just the fire, that it causes insulin and high glucose? And these are the mediators and the nutrients. When you have excess nutrients and you have hungrier cancer cells, you do a better job feeding them and they grow more rapidly. And people who are obese have a much worse prognosis of cancer. And cancer cells that have the highest uptake of glucose, which is stimulated by insulin, also tend to be our most aggressive tumors. So whether our nutrition and the quality of our food is the ignition or the spark or different in different people remains to be elucidated. But the combustion and the mix is really, really toxic. So when we go back to endometrial cancer, here's what happens when you're obese. Number one, the fat tissue is not inert. The fat tissue actually converts our testosterone into estrogen. So we have a high amount of estrogen. That estrogen causes a significant amount of proliferation in the uterine wall and stimulates uterine growth. We also, when we're obese, we're highly likely to have too many nutrients at our cells. When we have too many nutrients at our cells, that tells our body that we have too much traffic, and it creates insulin resistance. And what does insulin do? Insulin puts a lock on our fat. It makes us store fat in places like the liver, our muscle, our brain, and our pancreas, and tells our body not to burn fat, forcing us to burn more glucose. And what do? We have to go and eat more to make up that need because we only have a small reserve. So it creates this vicious cycle, explaining again that obese people don't eat more to become obese, they eat more because they're obese. And when they do so, they not only overfeed their body, they also overfeed cancer cells, making them more aggressive. So I guess my parting messages are that cancer rates and obesity rates are strongly related. So your diet and your nutrition are not just important for heart disease and diabetes and so-called metabolic diseases. And I think that we're going to think of cancer as not just a genetic disease, but as a metabolic disease. and that a poor diet may be the cause, but even if it's not the cause of your cancer, it's going to promote it and accelerate growth. And obese people are going to more likely have cancer. Their cancers are going to be harder to treat and prevent at an advanced stage. And tumor aggression really varies directly with the amount of nutrition that the tumor is getting. So obesity almost becomes like a perfect storm for tumor growth. And diet and lifestyle really do matter. And in the future, cancer will be thought of as a metabolic disease. So what's been really, really encouraging is there's now been bariatric surgical articles that have shown a reduction of cancer. And that doesn't mean that we should be doing more bariatric surgery, but it shows that our lifestyle does make a difference. And what we look forward to working with people who are part of this symposium is how we can treat this better and prevent this better, and what are the things that we can do. And I think we can add a lot of different things to this. One, we should be looking at fasting insulin levels, not just hemoglobin A1C. We should be looking at fasting glucose levels and more aggressively treat this. And the metabolic testing that I showed you pictures of is something that Dr. Villela and I would like to research. We can be able to tell what fuels our cancer patients are burning and then see whether we can make a difference by developing personalized nutrition and exercise programs that are based on their metrics, where they need to burn fat, and see if we can restore that. And we can follow biomarkers at an earlier stage than are traditionally followed in medicine. And we can continue to test. So I think that there's a lot of opportunity, and I really thank the symposium directors, the Ades family for making this possible, because this is so exciting, and we can offer so much more with diet, lifestyle, nutrition, testing, better biomarkers, and not just looking at how to kill cancer cells, but how to stop giving them the bad foods that really help them grow in perpetuity. Again, I'd like to thank the Ades family for making this possible. It is really, really exciting as we take people from different specialties and look at new approaches so that we can collaborate. And what we've kind of realized is that everything kind of works together, and having a more holistic approach that's based on wellness is not just a preventive mechanism, but can actually be treatment in the future. And thanks to the support of families like yours, we look forward to being able to make this happen.
Thank you, Dr. Roslin. That was a fantastic talk. I agree. We can offer so much with diet, lifestyle, nutrition, testing, and better biomarkers to determine how we can stop fueling cancer cells with the food that we eat to help them grow in perpetuity. Having a more holistic approach based in wellness is key. I'm looking forward to our future collaboration within the Jane Ades program to continue this work. The next talk expands on the concept of taking a more comprehensive and holistic approach to the continuum of cancer care. I am pleased to announce and introduce our panel discussion, who will speak on the comprehensive care to thrive through and beyond cancer. I will now turn it over to Dr. Catherine Alfano, Vice President of Cancer Care Management and Research, to lead us through the discussion.
Hi, everybody. I'm Catherine Alfano, Northwell's Vice President for Cancer Care Management and Research, and I am so excited to open the next part of our program today. So you've just heard about everything that you need to know to prevent a diagnosis of gynecologic cancer. But if you do wind up getting diagnosed, there are two things that you want. First, you want access to the most cutting-edge anti-cancer therapies that science can offer us right now. And second, you want access to a comprehensive care team that's looking out for you, helping to manage all of your other needs through and beyond your cancer therapy. These can be things like toxicities of cancer therapy or other needs that emerge as long-term or late effects of cancer therapy. And I'm so excited that we have 3 clinician leaders from across the Northwell system with us today to talk about 3 very important components of comprehensive care for our patients. First, we have Allison Asante. Allison has been practicing as a physician assistant for 13 years, with the last 10 years specializing specifically in gynecologic oncology. They're especially passionate about survivorship care and about helping patients adjust to life after a cancer diagnosis. They believe that patients should be active participants in their own care and encourage patient understanding of all of their medical conditions. Then we have Sharon Zarabi. Sharon is a registered dietitian with over 15 years of experience in bariatric surgery and weight loss, now working with the Katz Institute for Women's Health as a program director. At Katz, they're building clinical programs inclusive of a multidisciplinary team to navigate female patients to appropriate care at every age and stage of life. And next we have Dr. Susan Maltzer. Dr. Maltzer is the Vice Chair of Physical Medicine and Rehabilitation and the Vice Chair for Cancer Rehabilitation. She is passionate about bringing cancer rehabilitation and exercise to all patients going through cancer. So thrilled to have all 3 of you with us today. Allison, I'm going to start with you. What are the top 2 to 3 symptoms that you treat in gynecologic cancer patients, and what services do you provide to address them?
Great question. The most common symptoms I see in uterine cancer survivors are anxiety, depression, and sexual changes. Approximately 16 to 25% of all newly diagnosed cancer patients experience depression, and it's found that these symptoms continue into survivorship. Interestingly enough, depression and anxiety seem to impact a person's functional status more after treatment than during. I think the best way to address this is with specialized psycho-oncology support. The best interventions found thus far are cognitive behavioral therapy and medications as needed. Sexual changes also affect 60% of all gynecologic cancer survivors, regardless of their surgery type and treatment modality. The first thing I would say is make sure you're comfortable discussing sexual issues with your survivorship provider. Talking about it is the first step. From there, I recommend ensuring a patient has adequate lubrication and vaginal moisture, as well as pelvic floor physical therapy as needed with our rehab team. Pelvic floor PT is a really underutilized treatment for people with sexual, bladder, and bowel dysfunction.
Thank you. And now turning to you, Sharon. What are the top 2 to 3 symptoms that you're treating in gynecologic cancer patients, and what services can be provided for those patients?
Sure. So it's a great question. As a registered dietitian, I like to call myself the food doctor. And I think a lot of us know that food can either prevent disease and it can also actually treat disease. And what we put inside of our body is so important for the outcomes. So part of my role is to play Sherlock Holmes and kind of go through what the patients are putting inside of their body, because so many of our symptoms manifest in, GI pain, change in bowel habits, change in weight, as Allison just mentioned, pelvic pain. So a lot of the foods that we eat can contribute to these symptoms, and going through, your food log and seeing what it is that you're eating can help us identify where the dietitian can play a role in optimizing your health, making sure that you're eating whole foods, ensuring that you're getting all the phytochemicals and nutrients and minerals that you need, limiting processed foods that are high in carbohydrates and can actually trigger tumor growth or cause insulin resistance and inflammation in the body. So we'll go through a list of anti-inflammatory foods and foods that are high in these phytochemicals to help them across their health journey.
Thank you. And now, Dr. Maltzer, what are the top 2 to 3 symptoms that you're seeing in patients going through gynecologic cancer, and what are the services that you can offer them?
Thank you. As a cancer rehabilitation physician, what I do is try to address any loss of function or pain the patient may have as a result of cancer treatment. In patients that have gynecologic cancer, usually those are conditions such as neuropathy, lymphedema, which is a swelling of the legs, pelvic floor dysfunction, as has been mentioned earlier, and any kind of pain. And, one of the things that I do is work as part of a really multidisciplinary team, including physical therapy, occupational therapy, lymphedema therapy, psychology, sometimes speech therapy. And together we kind of come up with a plan for a patient that both addresses their pain and their function.
Thank you. And I love how all three of you highlighted the importance of working together in that team approach. That's so critical. So now turning back to you, Allison, how can patients access your services and when should they access your services?
So here at Northwell, survivorship care is generally embedded into the oncology offices, but that can be different depending on where you're treated. So the first thing I would say is reach out to your gynecologic oncologist. Personally, I care for patients at the Lenox Hill Gynecologic Oncology practice with Dr. Villela. Cancer survivorship truly starts at diagnosis, but often it becomes the focus after completion of treatment. Your survivorship care plan and your care team should be discussed in detail at your end of treatment visit. However, many of the symptoms and health issues we focus on during survivorship can start during treatment, so you should always bring up any concerns with your care team immediately.
Thank you. And Sharon, how and when can patients access your services?
Always a good time to reach out to a registered dietitian just to go through any wellness checkup is the same thing. It's good to go through your diet and see where improvements can be made. Northwell does have a variety of dietitians based on their specialties. So it'd probably be best to consult with your oncologist and they could refer you to a registered dietitian. Sometimes there are services that are in-house within the program. Otherwise, we are providing a list of directory of resources for dietary services.
Excellent. And now, Dr. Maltzer, how and when should patients access cancer rehabilitation?
I think the best time to access cancer rehabilitation would be as the patient is going through treatment and notices they may have any loss of function, pain, swelling, and to discuss with their oncologist a referral to cancer rehab services. We have both physical medicine and rehabilitation physicians and physical and lymphedema and pelvic floor therapists that your oncologist can refer you to. Northwell is really lucky to have a large network of both physicians and therapists, and we try to find locations that are near to the patient's home. I think the biggest part of knowing when to see a rehabilitation specialist is just being empowered to know that if you're suffering from problems such as pain or swelling or sexual dysfunction, that we have methods to address those problems.
That's so critical, Dr. Maltzer, right? I mean, we want to be looking out for you for all of the issues that need to be addressed, but part of it is we don't know to ask the question. So you need to tell your care team the issues that you're experiencing. So it really goes both ways. So next question back to you, Allison. Do you have advice for patients on how to prevent some of these problems in the first place and be proactive about that?
I think, like others have touched upon, the best prevention is focusing on your general wellness, including your physical and your emotional health. It's important to treat the whole person, not just the cancer or the cancer treatment symptoms. Ensuring you have a good support system and open communication with your oncology care team is the first step. As Dr. Roslin mentioned, in endometrial cancer survivors specifically, weight management is a critical factor. Managing obesity can both decrease a patient's recurrence risk and risks of other future health issues.
It's so important. Thank you. And now, Sharon, do you have advice for people on preventing some of these issues?
Yeah, I think a lot of people don't realize how much power and control they actually have on their health. And so much is impacted by our lifestyle. So again, beyond just what you eat, I'll usually sit with a patient and ask them, how much stress do they have in their life, and what stress management skills and tools are they active during the day? I know, speaking about exercise might be a little intimidating, but let's speak about how active you are physically throughout the day. Sleep hygiene is so important, and sleep is usually, underrated. And when we sleep, it's when all of the cells and our body is just recharging its batteries. So I think, as Allison mentioned, we need to look not at just silos of what's going on and looking at treating symptoms, but treating the whole person and understanding what is going on in their lives. And as we discussed, body fat percentage is so important. What are you doing to manage your weight? What are you doing to manage your blood pressure? What are you doing to manage your triglycerides and cholesterol levels? All that impact your metabolic system. And our metabolism has so much to do with how we utilize energy. So I think that we really need to look at the whole picture, not just one single number, and treat just from there.
Yeah, thank you for highlighting the importance of how these symptoms, these impairments in your function don't occur in isolation. They're really all, occur together. And so where we can get interventions that address a lot of problems at once, we want to be doing that. And certainly everything that we're talking about today is part of that. Dr. Maltzer, I know you have a passion for prevention. Tell us your advice for patients how to prevent some of the problems you've discussed.
I think one of the things that I'm very passionate about is that exercise is medicine. So exercise can actually prevent a lot of cancer-related side effects. So things like fatigue from chemotherapy or radiation, recovery from surgery, how your wounds heal, as well as preventing a condition known as lymphedema, can all be mitigated by the use of exercise. So I'm a big believer that from day one, before the patient has even had any treatment, they should be meeting the guidelines of how much exercise the patient should have. So staying as fit as possible will actually decrease some of the symptoms that you may experience during or after your treatment. I think one of the things also that I really encourage patients to do when they're first beginning treatment, other than exercise, is just to be very familiar with their body. So if you notice that you have a difference in the size of your leg or the size of your arm, or something doesn't feel right, don't wait for it to kind of get worse before you bring it to the attention of your physicians and other providers. I think being proactive and catching problems early in a lot of ways is preventative medicine.
I love that. And these are things that patients can do to take the reins of control back over their own health. So that's so important. Thank you, each of you, for highlighting that. Last question, Allison, back to you. Do you have recommendations on resources or tools or self-management materials that people hearing this today can use?
Absolutely. I think speaking about general cancer survivors, I really like the Livestrong Foundation and all of their educational resources. I always recommend cancer.net for accurate cancer information. It's managed by the American Society of Clinical Oncology. And looking specific to uterine cancer survivors, I really like SHARE. They have many offerings of support groups, educational events, and just a really great website full of information that's very specific to uterine cancer.
Thank you. And Sharon, what tips do you have for people on what they can use immediately after hearing this today?
Sure. So I think I created a few slides that I'd love to bring up and maybe just quickly run through those, because when it comes to eating, they're healthy. There's a lot of noise out there in the diet culture. So number one is, and I think this goes to everything that we spoke about, whether it's, the behavioral therapy, the physical therapy, it's to be consistent. We need to be consistent with what we do. Whenever we have a goal, showing up and being clear on what it is on a daily basis. So just try to find the time in your day to make this a priority. We can go on to the next slide. As I mentioned before, trying to eat as close to Mother Nature as possible. So using whole foods that are rich in different colors. The more darker colored vegetables and fruits have more phytochemicals and minerals. And I always say, if your grandma never ate it, neither should you. We can go on to the next slide. And the 80-20 rule, I know a lot of people get intimidated when it comes to meeting with a dietitian or any healthcare professional because they think that we're really strict and you need to follow all the rules. But I like to follow the 80-20 rule with every aspect of my life. No one is perfect 100% of the time. So we need to be a little bit more kind and generous to ourselves and compassionate when we're not achieving the 100% goal. But knowing that you're following the guidelines 80% of the time is still, you're ahead of many. So I like to put that bucket and learning to savor treats guilt-free. And lastly, one more slide. When I talk about diets versus being healthy, when we think about diets, they're usually not very sustainable. You don't want to do anything that's too extreme. So working with a dietitian can help guide you through your meal planning to make it something that can be sustainable. And if you look at the word healthy, you'll see the word heal. So we are here to heal our bodies from the inside out.
Fantastic advice, whether you're going through cancer treatment or living beyond cancer treatment or just for everybody out there. Thank you. Dr. Maltzer, what resources or tools or self-management materials do you want to tell people about?
I really like the American Cancer Society has a lot of information for cancer survivors, and it has information on things like lymphedema, cancer-related fatigue, neuropathy, all the things that rehabilitation medicine and our cancer rehabilitation team treats. I think it's important to get your information from a reputable source because I think there's a lot of misinformation on the internet. And so I really like to use sites like the American Cancer Society for patient education.
Thank you so much. And thanks to all three of you on the panel. I want to leave you all with this. Hopefully you're hearing that if you get diagnosed with gynecologic cancer, we at Northwell are with you every step of the way, but we also need you to be with us, right? Tell us what's going on with you. Be proactive about helping us help you. And with that, I will now hand things back to Dr. Villela for questions.
Thank you all. That was an incredible panel discussion. I think each of you provided practical tips and guidance to help individuals access comprehensive cancer care. We hope you found this session informative. The Jane Ades Gynecologic Cancer Symposium will be an annual event, and we will look forward to continuing to provide you with vital educational information to empower you and your families. Thank you again, Mr. Paul Ades and his family, for their generosity and for making today's event possible. I now invite you to join us in a Q&A session. We look forward to hearing and answering your questions. Okay, so we're going to get started with some questions. Feel free to, post a question in the chat. You just press the chat button, and then you can type in the question, and I'll read it out. So we have a few here. The first one is for Susan. Are there examples of exercise that you'd recommend for patients who are feeling tired and fatigued and not really up for the gym?
Great. It's a really great question. Thank you for asking. My recommendation is always patient specific. So if a patient sitting in front of me was a marathon runner and was going to the gym daily, I encourage them to start getting back to their regular activities. If my patient was sedentary and didn't exercise much, I encourage them to begin with the walking program. And I make it very simple. Set a small goal for yourself, try to go up every day and do something that's fun. So in the summer months or when the weather is good, I always encourage patients to be outside. And then I encourage them to look for things that are fun. So biking, kayaking, rowing, dancing, you name it, all is physical activity and is all exercise. But I think it's also important to note that it doesn't have to be all or none. We don't have to be going to the gym, sweating on a treadmill, or sitting on the couch and doing nothing. Every movement we do gets us some exercise units, as I call them.
Okay, thank you so much. The next one is for Sharon. Eating healthy can be expensive. Do you have any tips for healthy eating on a budget?
Oh, that's a good one. So it is true that foods that come and are sourced from farms and require a lot more work and a lot more input versus a potato chip that was highly processed and packaged in a bag and sitting on a shelf for God knows how long. I think there was once a study that a Twinkie that's even 20 years old has a shelf life and it still tastes good because it's all covered in sugar. And I think from Dr. Rosalind's talk, we learned what happens in the cells when we take in a lot of sugar. So it's going to, it should be part of budgeting. Frozen vegetables are always a great resource because they don't go bad. I always hear my patients saying, if I go to the market and I don't use all the salads or the veggies that I bought, I have to toss them out by the end of the week. And I said, well, if you use them, you wouldn't have to toss them out. So I think it comes back to planning how your meals are going to be, consumed or broken down. And it's always good to kind of like recycle your meals. If you're making grilled chicken one night, jazz it up. One day, put some teriyaki sauce on it. Another day, put some other seasonings on it. Another, make, a salad with a little bit of mayo and add some, chopped up fruits and chopped up nuts. So you're utilizing everything in your pantry and in your refrigerator. So there's less waste. And it's still a highly nutrient dense meal.
Thank you very much. The next one for Allison. The fertility sparing treatments that were mentioned are very interesting. Are these services provided at Northwell?
Absolutely. We work very closely with our fertility and reproductive endocrinology counterparts. One of the best parts of uterine cancer is that for a lot of our patients, fertility sparing treatment is an option, and it tends to respond well to non-invasive, like non-surgical treatments. But what's hard is then when your cancer has responded and you need to get help getting pregnant, mostly because we really are on a little bit of a time crunch. So we often send people to our reproductive endocrinologists, who at Northwell, we have many that are well-versed in all different types of cancer, but especially uterine cancer survivors, really just to make sure that people's hormone exposure is minimized and that if they'd like to get pregnant, it's happening quickly for the patient's safety.
Okay, thank you so much. Yeah, and I believe that there are actually several methodologies used for fertility-sparing treatments when it comes to reproductive endocrinology. They can provide you with even more information. So we work very closely together. Thank you, Allison. Okay, Dr. Rosalind, we've heard a lot about our mitochondria and its effect and its importance in metabolism. And how can we change the effect of mitochondria since we inherit this from our mother and that's something we cannot change?
Well, I guess the answer can't be find a new mother. So that probably wouldn't work. Again, I think this is really the real interesting thing. And probably what I would say is that we probably need more sustained activity at a lower level. When Dr. Maltzer was speaking, she said that, getting off the couch is important, but probably from a metabolic standpoint, especially for people who are not potentially in the best cardiovascular shape, it may be more sustained exercise at a lower heart rate is what's going to recruit more mitochondrial function in the burning of fat. What probably happens is elite athletes will burn fat out to a very, very, very high heart rate. And once people become insulin resistant, that gets vastly reduced. And I think it's really, really important that we have people do a lot of sustained things at a lower intensity level would probably be the only answer that I'd have at the present time. And that may be different for different people.
Okay, thank you very much. Okay, we have another question in the chat. Are there any studies or figures on endometrial cancer in the female to male trans community, and can testosterone increase or decrease the risk of endometrial cancer? Allison, do you want to take that?
Yeah, absolutely. It's a great question. Unfortunately, when you look at a lot of things in the trans community, we don't have dedicated research to really give a clear risk stratification. So the short answer to your question is no. There are no studies that really look at this population and the effect on hormones and really most cancers, but also uterine cancer. When you look scientifically, we have some thoughts about risk stratification. One is that if you have an excess of androgens, that can theoretically be broken down to estrogen. So it's important, someone on testosterone, to have close follow-up with an endocrinologist to make sure that they're not taking too much testosterone, because the thought is that taking too much testosterone can actually increase the amount of estrogen in your body. The more likely thing is that trans men or the trans population in general have different social determinants of health and risk factors than other populations. So, the trans men are more likely to be obese, which, as Dr. Rothwell and Dr. Villela touched on, have a big impact in uterine cancer. But we really don't have definitive answers.
Thank you, Allison. Okay, the last question here. Are there genetic tests myself or my family can pursue for the hereditary forms of endometrial cancer? So I can answer this question. Only about 5% of endometrial cancers are due to genetic causes that predispose you to early onset cancers, and even in the 20s and 30s. So it's really important for you to have a comprehensive family history and make sure that that's updated. Just like you update many things in your life, that's a very important part of your medical history that you have updated, and that you always share that with your medical providers. If you notice that someone in your family has early onset cancers in their 20s, 30s, 40s, early 50s, multiple cancers in the same individual, those are some, really important things to note, and that could be indicative of a genetic cancer. But what's most important is that we actually test the person with the cancer, because if the person with the cancer is negative, then in many instances, the rest of the family is not at risk for that genetic mutation, because the person who's affected by the cancer isn't caused by a genetic disease. So it's very important for you to update your family history, discuss this with your provider, and also be an advocate for yourself, and reminding physician, do you think I need to be tested for any genetic cancers? So thanks for that question. And that concludes our program. We would like to thank you for your participation today. I would again like to thank Paul Ades and his wonderful family for making this possible. If we didn't get to your question today, please email them to the email, which will be on the next slide, and we'll get back to you. And please look out for a follow-up email with a brief survey and a link to this talk, which will be on YouTube. And we want to thank you on behalf of all of us and at Northwell Health, and we're here for you for all your needs. Thank you.